as people are trickling back in from the poster session, we'll get started on our next section for today. I'm Catherine Uhazy, and I'm delighted to moderate our next section, which is retinal degeneration, pathogenesis, and therapy. Our first speaker is co-director of the Center for Hereditary Retinal Degenerations here at Penn, Dr. Artur Cideciyan, and he'll be speaking about antisense versus gene replacement therapy for improving vision in IRDs.
Hello, good morning. I will try the old-fashioned way here with the mouse. All right, we tend to, this morning obviously we heard from Eric and Jessica a lot about inherited retinal diseases. That's all we do. It is a group of disorders I like to define as that are caused by single gene defects acting in or on photoreceptors and or on the RPE. And a lot of people think of the last 35 years as the incredible molecular advances that have made us understand a lot about inherited retinal diseases. And we usually think of the current moment we are in, which is more than 300 genes, thousands of mutations causing this group of disorders. But I'd like to take you back for a second, 35 years to the start of this. And back right near the start, there were two discoveries that happened back to back. One was what Jeremy Nathans and colleagues discovered molecular cause of cone opsin mutations causing blue cone monochromacy. And a few months later, Ted Dryja, Elliot Burson, and colleagues discovered rhodopsin gene mutations causing autosomal dominant retinitis pigmentosa. At the time, maybe it was not as obvious as it is now, but these are two very different diseases that kind of started this whole thing. And the reason they are very different is because in the first case, in blue cone monochromacy, what happens is that there is a huge dysfunction. There is a set of cells, a subset of cone cells, that have very bad function or no function, but they remain there anatomically. And that is true early in the disease and late in the disease, and there's very little progression. That is very different than the second one that was immediately thereafter discovered, where both the anatomy as well as the function of photoreceptors are presumed to be totally normal for a certain period of time. And then there is an onset of disease. We don't understand how this happens, but from that point on, it rolls down this mostly exponential trajectory of losing photoreceptors and thus losing function. So why am I emphasizing this? The reason I'm emphasizing is because treatment approaches for these two, as well as many other related conditions, are very different. They can be all gene-targeted treatments, but with very different goals. In the case of the blue cone monochromacy example I showed, the goal is vision improvement. And then the therapy can happen at any time during the natural history of the disease. And one would expect, if it was working correctly, a quick improvement would be the result. Whereas in the degenerative conditions, such as the example of the autosomal dominant retinitis pigmentosa, the treatment, if it's done early, can arrest future vision loss, or if it's done later, at least allows the patient to retain whatever level of vision and anatomy that they have. So that would be the ideal goals. So we have been, I like to think, quite successful in this category of treatments, and we have been quite unsuccessful, and maybe even almost none to show for, in the second category. And Eric wonderfully listed a whole bunch of challenging results, and many of them were in this category except for the CNG A3 and B3 diseases, such as RPGR, et cetera, which have been mostly failures or challenging results, let's say. So what has been the successes here. The successes have been in these congenital loss of both rod and cone function diseases as a general term usually classified under Leber congenital amaurosis. And this is a term that relates to many different molecular causes, something around 25 different causes, some of which are listed on the left. And they all are expressed at different cells, different subcellular regions, and they are distinct pathomechanisms. So there is nothing necessarily common about them, but with, as I mentioned, quite a few successes. Specifically, 6 of them, to my count, have been in the clinic with some results. Thomas will talk about the LCA5, and I like to talk about 2 of these, which is the CEP290 and guanylate cyclase. And again, Eric introduced the CEP290 version this morning. Just to repeat, CEP290 is expressed in the transition zone between the outer segment and inner segment of the photoreceptors, and it's somehow involved in the trafficking of many proteins back and forth through these subcellular organelles. And again, what he mentioned before, that there is an amazing retention of anatomy in patients with very severe vision loss. Here's one example of a 15-year-old with light perception vision, but clearly a retention of both outer nuclear layer as well as some outer segment and inner segment structures. And the same patient retaining melanization of the RPE right near the center of the macula. So that opens the door for considering gene-directed therapies. Something like 70% of the alleles causing CEP290 form of the disease is due to this single intronic mutation that is thought to be a founder mutation that produces a splicing defect. And splicing defects such as this has been known for more than a decade that in theory can be ameliorated with antisense oligonucleotides. This was indeed the direction taken by a company called PureQR that generated this antisense oligonucleotide called cepofarsen that was to be injected intravitreally. And the aim of this injection or this therapy was to change the balance between wild-type protein and mutant protein towards the greater amount of wild-type protein. A clinical early phase 1/2 clinical trial was formed. We were lucky to be part of that, and we have been trying to publish many of those findings over time. What I'd like to talk to you about in this talk is one of these patients, P11. There was something very special about this 14-year-old at the start of the trial, and we followed him for almost 4.5 years. And the reason it was special is because this therapy that was intended to be injected every 3 months into the vitreous, instead the patient refused these injections. So we had an opportunity to see a single injection shown by the red star and follow him for nearly 4 years after this single injection, and then a repeat injection in the same eye. In the meantime, a second trial started for the contralateral eye, and we had the opportunity to inject his second eye with a single injection after about a year of following that eye without an injection. So we had opportunities for long-term follow-up as well as a very long startup period with multiple measurements. I don't want to necessarily go into much detail about his results, except to say that both using static perimetry as well as microperimetry, looking at the area near the fovea, at the fovea, or in the parafoveal region, what is common among all these curves with independent measurements is that there is a period of baseline shown on the left before time 0, and then for the next 4 years, and the scale is important, for the next 4 years, there is a stepwise increase in function we are measuring and a slow roll-off towards baseline over 4 years. And that's true at the fovea, parafovea, with different types of measures. Indeed, when we used a different measure called FST, full field sensitivity testing, which measures any point in the retina that has the best sensitivity, both under dark adapted conditions as well as light adapted conditions, very similar effect, a baseline stepwise change and a slow roll-off. When we look at the ETDRS visual acuity, we see the same effect except a small change. This is about 5 to 7 log units, 5 to 7 letters, about a line. However, when we do the visual acuity under dark adapted conditions, which is also called low luminance visual acuity, this change was quite dramatic, more like 20 letters or 3 to 4 lines, and again, similar pattern of a stepwise change and slow roll-off over the same period of time, about 4 years. So the conclusion from this specific patient and other patients in this trial is that there is a pattern that one can describe as increase in light sensitivity occurring very quickly following an intravitreal injection of the antisense oligonucleotide and a slow roll-off of over the next 3 to 4 years towards baseline. And again, the significance of that is that it was initially thought that injections would be required every 3 months, and I would argue this curve clearly suggests that that's the wrong interpretation. So I'd like to then move on as a comparison to a different disease that is caused by guanylate cyclase mutations, also called LCA1. Guanylate cyclase is involved in retinal phototransduction, both in the rods and cone photoreceptors, and it's involved in the recovery after a light-driven phototransduction. Very similar to the other condition, there is a lot of photoreceptors, even though very severe disease, and that is true throughout the natural history of disease from age 1 to age 59. These are all Leber congenital amaurosis patients with very severe vision loss and clearly with very retained retinas by OCT. Again, we were lucky to be involved in this kind of a early phase trial, and we try to publish as much as we can about the findings. But here are some of the basic ideas. In a cohort of 9 patients, all receiving the same high dose, there was some increase in visual acuity, but that was not statistically significant. However, when one looked at light sensitivity measured by FST, there were highly significant improvements, in this case about 2 log units or 20 dB, shown by the red dots as compared to the contralateral untreated eyes shown by blue, and the time scale here is 1 year. As you can see, there is very large variability across these 9 patients with the error bars, and what I like to show is 2 hyperresponders who had ability to perform very many tests, and thus we could be more confident about their results with a variety of independent tests. And they showed quite dramatic improvements of night vision, importantly night vision and not day vision. So the scale here is 50 decibels or 5 log units or 100,000 fold. Very quickly after the injection of subretinal injection, there is an improvement, and that improvement is kind of a stepwise and is retained for the next 3 years as compared to the contralateral eye. And the other patient shows a similar improvement also, a very large improvement, and retained over time. We were very interested in these stepwise improvements and how they change within the retina. And these two patients are shown here in terms of their retinas, and three little dots at 6, 12, and 18 degrees from the fovea are individually evaluated with the plots next to them. And they all show the same kind of pattern, which is quick improvement and a slow further improvement. However, there are differences. Some locations, such as 18 degrees here in P2, there is a relatively large delayed improvement, and similarly, centrally in this patient, that there is this relatively large delayed improvement, whereas in other locations, most of the improvement was already already achieved in the first 3 months. So the take-home message that I'd like you to take away is a few things. One is the shape of the function. So these are improvements in the vertical direction. The antisense oligonucleotide on the bottom, the gene therapy, subretinal gene therapy on the top. And subretinal gene therapy after time 0 shows this stepwise improvement that is retained up to 3 years. We will, of course, continue to follow these patients. Whereas in the antisense oligonucleotide, as expected, there is a roll-off. However, the roll-off is very slow as compared to the expected 2 to 3 month pharmacokinetics, whereas the pharmacodynamics of the actual results in the patients is almost 10-fold slower. And so we need to think about some of these effects. Also important to remember is this is all coming from rod photoreceptors outside of the fovea, whereas the antisense oligonucleotide results are coming from foveal cones. We don't have results from rods in this kind of therapy, and we don't have results from cones in this type of therapy. So it's kind of an apples and oranges comparison, and that's important to remember. The other thing to remember is this vertical scale. These are in log units, so this is a huge scale for rods and much smaller for cones, which is consistent with what we have seen in many other diseases, where, including the original RP65 work, where the improvements to cones seem to be, even in the best of the cases of patients, seem to be much smaller in amplitude than the improvements that are possible in rods, and we need to think about the implications of that. In conclusion, these are all my wonderful colleagues that I've worked with many years, and especially both of these projects would be impossible without Sam Jacobson, our colleague and friend and advisor, who passed away a couple of years ago, and many collaborators. And as usual, it takes more than a village to do some of these things. Thank you.
Art, congratulations on these successful therapies. So the CEP290 is, like you implied, is really remarkable that it lasts so long. It's a nucleic acid that's injected into the vitreous or the
Vitreous.
Vitreous. Is it in nanoparticles or just naked?
It is an antisense oligonucleotide.
Okay.
So it's
Just naked nucleic acid.
yes.
So it gets into the cells, and then the half-life of the molecule is only a few months, and yet the effect is much longer. So how might you explain that?
Yeah, we had actually produced a bunch of videos of what we think speculated as to what may be happening. So the short answer is we think there's two effects. One is, unlike gene therapy, it actually takes 3 months or so for the full effect to appear, the peak effect, which is slow. The antisense oligonucleotide gets to the cell probably within the first hour or two. So why does it take 3 to 5 months? And we think that the multi-protein complex that CEP290 and many other MPHP5 molecules are formed in this isthmus of the connecting cilium takes time to build. And if that's true, it probably takes time to turn over. So what we are watching is, with the visual function, is the turnover time of a protein that was formed 3 years earlier. So when people think about the pharmacokinetics and they make measurements in NHPs and mice about the molecule, they're not thinking about that the molecule may be gone, but its effect may last for a very long time. Dwight?
One last question.
Rationale for doing intravitreal for the JUC?
So the intravitreal for the CEP290 was the usual rationale, which is, if you want to treat a lot of patients in the office for much more conveniently, so everybody would prefer, obviously, an intravitreal injection compared to a subretinal injection. In the case of guanylate cyclase, the preclinical work was with subretinal injections in mice and chickens and a variety NHPs. So they followed the preclinical work of gene therapy. And as some of you know, gene therapy intravitreally has been quite challenging to achieve without inflammation.
Okay, thank you so much.
Thank you.